afternoon, everyone. We're going to talk on pathology a little bit that I didn't finish last class on gastrointestinal chapter. And it's basically about some malabsorption and a little bit of cancer of colon that I believe is important for you as clinicians to understand and make either a good diagnosis or at least think about it with some signs and symptoms. With malabsorption, there's some digestive problems, of course, but they can come from different aspects, like either you have more bacteria, you have deficiency of some pancreatic juices because of chronic pancreatitis. There should be an H there. Deficiency of bile, and everything has to do with protein, with fatty meals, and or if you happen to have bariatric surgery or have surgery of the stomach because of cancer, you're going to have some post-gastrectomy conditions. And one of these, or an atrophic condition, remember that it's the lack of intrinsic factor and not being able to have that nutrient. So anemia, the type of megaloblastic anemia, that's what you have, or pernicious anemia, that's called. So any of these things, just review them in a way to understand where do you think in your scope of practice you will be getting some sort of information for that matter. Celiac sprue and tropical sprue are two types of diarrhea, see it that way. The celiac sprue has to do with gluten. So if you recall, many of the new advertisement in food or products are gluten-free because there's some specific features with this type of uptake of nutrients and people that are allergic to that. Tropical sprue has to do more with what it says there as tropical areas, and it's another type of condition that goes along with some diarrhea. Any of the other have to do with some situations where you do not have capacity from the intestinal lumen to get that type of nutrients or from the food and being able to process it. Probably one thing, even though it says infectious enteritis, I would add one thing else here that comes from antibiotics. And probably this is something important as well as with anti-inflammatory medication. The non-steroidal medications, even as Advil or Motrin, Aleve, or some specific antibiotics will cause a little bit of the intestinal mucosa to be swept away. Once that is swept away, it's getting not being there anymore, denuded, if you want to call it. It leaves a very specific part of that large intestine prone for any bacteria to get in and produce disastrous situations there. Megacolon is the name of that situation, or toxic colon is the name of that condition. And what that toxic colon is, death is very close if not good care is taken with these patients. So just again, they're not eating well, but then they also have kind of a fatal condition. So think about all the situations. Some of them are related with autoimmune system, autoimmune type of conditions. Whipple's disease is another type. So think about any of those, as many as you can, to understand what are the chances of you looking at some of these patients. They're going to be weak, not enough strength. They have diarrhea, so they might be dehydrated, and you're asking them to do some sort of exercises or place them in some sort of program. So transport of nutrients as a defective type is because you have some specific conditions as lymphoma, amyloidosis, scleroderma, anything that, even I would add here, for example, Parkinson's. Parkinson's disease brings down all the metabolic action of intestines to move, and they are constipated. Now the opioid type of constipation that has to do in relationship with all those painkillers that are given, all of these patients result in an defective transport of nutrients because they are not capable of moving weight. So some neoplasms that might be seen, we're just going to relate one, which is the colon, and this is the most important one for you for many reasons. One of the things is that they can be primary, secondary, and they can be solitary or multiple. Most of them are going to be either adenomas or carcinomas. That's 90% of all tumors, much more than lymphomas or mesenchymal tumors. But the thing is that many people are affected per year in this country. And one of the things is very close relation, has or keeps a very close relationship with being constipated, not eating enough fiber, but also must have another, like I keep saying or telling you, that you have to have something that triggers it. So you have to have that in your DNA in some way. Genetic factors play important roles, so something has to do with that. Dietary factors, low fiber, high carbohydrate, high fat content. Some interaction of oncogenes, tumor suppressor genes that are not there anymore because of the DNA or your hereditary trait. So if you add a little bit of each one, the chances are higher for that purpose. Some specific classifications as being malignant, like I said, always add the word carcinoma. You know, lymphoma or sarcoma are not benign. And benigns have just this oma added to the end as a suffix, and those also have a different type of sources as etiology or tissue, and some hyperplastic polyps they are not considered neoplasms. So any of these situations is important for you to follow. The schematic view and one photograph of a colon in this case to show those polyps. They're just overgrowth or growths of tissue in normal status, but they just grow in a way by different circumstances. Adenocarcinoma of the colon is something different. Not necessarily comes from a polyp, but the important thing is that the places where they can be located, one of the most common site is exactly at the rectum, where the distal sigmoid column ends, the rectum begins, and it's about a finger length to touch it. So sometimes chances of having some symptoms, if your patient or yourself or somebody that you know is having some rectal bleeding and probably some low pelvic pain, probably a rectal examination is more than enough to feel something there because of the chances in the statistics, which is a higher one. Some of the ones on the right side or transverse are silent. So those are that's why this is so difficult to really understand how to make a very early diagnosis to have better chances of survival. Some of them will be ulcerated, and once they ulcerate, they can bleed. Pain is typical, but if you understand that you might have some abdominal pain once in a while, you're not going to be able to really pinpoint to, hey, let me take a look at this. Some of the features in a macroscopic eye view of this, how those that tissue is completely abnormal. Glands that you might see, if you recall a little bit of those comments as being glandular, and you see some different type of cells, and some are smaller. So there's a complete disarrangement of a normal anatomy or the normal histology. That histology is going to give you a pathological state. Probably this one is an interesting aspect. Let me show you up here, way up here. You can see all these cells are more or less aligned, and this one is completely disarranged, as same as this other side. So that's how you see the cells are not normal. They have metaplasia, dysplasia. If you could see the nucleus, probably you can see that there's a lot of mitosis, so a lot of pleomorphism is present there. So that's important as for diagnosis, and to understand that that the antigen, the carcinoembryonic antigen, CEA, is going to be the one to do that initial diagnosis from the lab. The gastrointestinal carcinoids, and we reviewed in the previous slides, 90% are going to occur in intestines. And the appendix is the most common site of origin. And this is something that has to do with composed of some cells that are very specialized as neuroendocrine cells. And these are going to be producing some polypeptide hormones. And because of that, there are going to be some changes as those tumors secrete serotonin, and those hormones are going to give diarrhea, hypermotility of intestines, just because of the nature of that hormone being secreted once those small tumors are present. And these are considered to be benign. So it's important just to having somebody that you could know that has, for no reason, diarrhea, a lot of hypermotility of intestinal structures. Just think about the concept of this situation of GI carcinoids. Something that you can see it like a bump there, a small lump, that's what it is. Not really to see here. And so we'll end up with this, in this matter, this GI lecture, but then we're gonna move into the following, which is the liver. And biliary system. So we'll move fast here. You already know from anatomy the four lobes that form the liver, the normal liver. And hilus, that's where the point of entrance of these structures as bile ducts, the hepatic artery and portal vein enter. That's the triad of the liver, if you recall from last term. Gleason's capsule is a capsule that surrounds, does an envelope to the liver, and this capsule is the one that is going to give pain, or the terminal nerves are there, and anything that happens as swelling or something about the liver is going to give pain through Gleason's capsule. Remember what a triad was, so go over as the lobules that you'll find in the liver, as well as you have in the arranged in your lungs. You have also lobes in the liver. So the portal tract, as portal triad, is going to have the artery, the vein, and also you're going to have a duct. So there's a central vein for this. The specific cells that are called Kupffer cells are in the sinusoids, and these are for the function of phagocytosis. Functions that are going to have in general terms for a normal liver is producing bile, is from the metabolic process, anything that has to do with toxic waste or toxins that are there, some storage, specifically for carbohydrates and lipids. And remember that for synthesis of proteins, the immunoglobulins are the ones that are going to be as major plasma proteins, except immunoglobulins. So the major plasma proteins as albumin, the coagulation proteins and transport proteins are the ones that are going to be related with the function, not the production of immunoglobulins. some syndromes that turn you into in a yellow tincture, jaundice, hepatitis, some injury, cirrhosis is going to be seen today. So think about trying to remember what the hepatic portal system was, the junction of the superior mesenteric vein and the splenic vein coming from all the structures, intra-abdominal structures. So if liver receives these nutrients absorbed from intestines via the portal veins, and this portal vein is self-contained, which means that there's no functional communication with the inferior vena cava. Unless there's something that increases that pressure, then there's an anatomic shunt. And once that happens, from the portal system, goes directly to the inferior vena cava, and then everything starts into collapsing or just increasing volume in other places. So when there's some obstruction of the liver, mainly because of cirrhosis, that increased pressure is going to go to the portal system. This will open those anastomosis from the portal to the systemic, which is the inferior vena cava. So once that happens, all that blood is going to bypass the liver and not being able, the liver, to do what it has to do as metabolic processes to get rid of all those waste toxins and other metabolites. Basically ammonia that comes from the protein catabolism, and will eventually lead to some condition that is called the hepatic encephalopathy. When this happens also, blood will lack some specific metabolic structures or substances like plasma protein, coagulation protein, and typically the person goes in or falls into hypoglycemia. The important thing here is that if coagulation proteins are not being formed, then bleeding tendencies are high. And what happens once everything of the liver is being held in a way that it's obstructed, there's a backflow of all the rest of the system, of the hepatic or portal system, and then the spleen starts increasing in volume or size. Then all the blood in your abdomen is holding on, and also you have more fluid, as a sinus is called, and this is just by passive congestion. So varicose veins start to develop, either from the hemorrhoids and most likely from the esophagus, and that's going to be even considered to be a fatal condition if these esophageal veins rupture and start bleeding. Jaundice means, from icterus, means yellow. This is a sign, not a diagnosis. So important to think or to know that when you have higher levels of bilirubin, basically just about over 3 milligrams per deciliter, you start getting this yellowish tincture in the inner side of your eye. The white side of your eye is going to turn yellow. Probably underneath your tongue, you can see a yellow tincture. A little bit on your nails, you can see some yellowish tincture, and that's jaundice. There's 3 types: the pre-hepatic, hepatic, or post-hepatic. And it has to do with the liver. Pre is before and the liver area, and post after the bilirubin has been, in this case, synthesized, and we'll review this. Now, bilirubin is important for you to understand that derives from the part of the hemoglobin, which is Hem. 70% is going to be red blood cells in origin, and 30% come from other tissues, specifically respiratory enzyme and bone marrow precursors that are not utilized. But the thing is that all red blood cells are taken mostly if they're over 120 days old, and these are taken either by the spleen or by the liver, by those specific cells. Here in this one, you can see as a major cause hemolysis in the hepatic phase or hepatic classification, presentation, viral hepatitis, some drugs, cirrhosis tumors, and the post-hepatic is because of gallstones or cancer of the pancreas, cancer of bile ducts, somewhere there. But this is the type of jaundice that you might have. And the important thing has to do with some conjugation that you'll see. So the prehepatic is unconjugated bilirubin, which means that this is not water soluble. When it's taken by liver cells, it should be conjugated to glucuronide, and this will become or be water soluble. So the unconjugated bilirubin as prehepatic by excessive formation is going to cause hemolysis. Malaria is the most common cause worldwide, and there's one specific condition that's called Gilbert's disease, and doesn't give a huge amount, it's not dangerous, but you might see some people that are a little bit more the yellowish tincture, and if they get their bilirubin levels, they're going to find out that probably they're 1.5 to 2 milligrams per deciliter, doesn't reach the 3 in many times. The important thing to know for you here is that we'll stain those tissues as yellow, but the urine is going to be normal regardless of hemolysis. Typically hemolysis will lead to something like this, but to make a diagnosis here is that besides hemolysis, you have normal urine, you're getting to be jaundice, so you're going to have this situation as understanding being prehepatic unconjugated bilirubin, and that's the reason why. And so this is something that happens at that level, from being normal when that bilirubin goes to the liver, conjugates to glucuronide, and then is water soluble. That's the normal. But this is something that has to do with not being able to do that path. The hepatic is that the conjugated bilirubin excreted and bile into gut. It gets the digestion of dietary fat, but bilirubin is not being used. So here, bacteria turns this into urobilinogen. This is reabsorbed to the liver. Now here, the conjugated hyperbilirubinemia is going to be given or being caused because at the level of the liver, there's either some obstruction of that bile flow, which increases a level at that common bile duct. Now, conjugated jaundice means that it's water soluble. So there was, from the bilirubin joining or going conjugated to that glucuronide, here, that's what happens. So there's a high content of this bilirubin that's going to give you a urine that is stained or in color, brown color. It's typically called as like Coca-Cola, means that it's just dark. What conditions might cause this? Viral hepatitis, alcoholic liver disease, or any of these conditions. When you have this type of obstructive jaundice, you have two situations as urine and feces. The feces, it's called acolia. Acolia means that the stools have no color, so they don't have this bile there, so they remain as color of clay, and they happen to have brown urine like Coca-Cola. The post-hepatic, like I said, is something that has to do with once everything's conjugated, going out, but it doesn't go out normally. And same thing here as clinical signs and symptoms, or signs from urine and feces. You're going to have acolia and you're going to have brown urine. So only the first one, the prehepatic, will give normal urine. That's the only thing that you're going to have. The stain or yellowish color you're going to have. Also, your stools are going to be normal with a prehepatic jaundice. But this is something that has to do with obstruction of bile flow. So anything that has to do with ducts or something at the pancreas or the second part of the duodenum is going to give a backflow to the liver, this matter. So you can find it here. This is kind of a yellowish tincture and sclera. The other thing is that when you have high levels of jaundice, typically you're going to have a lot of itching. So it's something that's very close related to that. So the unconjugated bilirubin, it bounds to albumin. It doesn't cross the blood-brain barrier, so it will not appear in your CSF, doesn't filter through urine. So in hemolytic jaundice, this urine is normal. When conjugated jaundice happens, that's water soluble. This is excreted urine, and that's when there's high content of bilirubin, you get brown urine. Plus also because of the condition that goes into the gut, it's not going to be able to metabolize those that content, and it's going to come as color of clay. One of the pathologies that are very common is hepatitis, which means inflammation, swelling of the liver. There are many causes. Virus is going to be the one that we're going to discuss now. So A, B, C, D, E are the type of viruses for hepatitis that you might find. The important thing here is that, as you recall from the first classes of pathology, the virus was going to go into the cell and it's going to change that DNA through the RNA, is going to damage and disrupting some very specific vital functions of the cell. And by disrupting those vital functions of the cell, that's going to cause death. Some rare causes of hepatitis have been distinguished as any of these other type of virus that are affecting. Thing to understand is that, for example, most of these hepatitis or hepatotropic virus might be asymptomatic, but 40% might have some antibodies to hepatitis A virus. So the hepatitis A virus is not encapsulated RNA. It's very similar to poliovirus or any of the gastrointestinal virus, which are called the picornavirus. One of the important things is for you to remember and understand is the fecal oral route. So it means that's why you have to wash your hands after meals. Now you go to a restaurant, you don't know the cook. That guy probably has hepatitis, early onset, has diarrhea, doesn't wash his hands, probably gets contaminated with feces, rushes to make your hamburger, and there you go. Now you're going to have hepatitis A. In some places in the past, there used to be a situation where you could have in a race, you will have some huge jugs of water, so you can just scoop a cup or something and just get it like this, but your hand was all the way in. Same thing. They're running, probably they had a diarrhea, probably they are sick, they feel bad, they have to drink more water, but they have wanted to have a 5K race or something like that. So just think about ways of transmission or contamination. Most of these are either sporadic, which is when it comes to endemic is a big situation. Some other names have been coming around, like norovirus, and again another cruise, what the anthem of the sea ship had again some good amount of passengers with diarrhea. Some meals or some things that can be contaminated, the sewage, shellfish, and this is typically more in children, underdeveloped countries that will get hepatitis A. It has a very short incubation period, about 2 weeks, and can be as much as probably close to over 2 months. It does have a auto or self-limited condition, which is typically mild, of course, might have some fever, vomiting, loss of appetite, but they get yellow. One of the things that many people remember, recall hepatitis A or being infected with or condition of hepatitis A, they get to eat a lot of candy. they thought that probably they had to eat a lot of sugar for recovery. Otherwise, it's just a myth about that. In hepatitis B, this is the only DNA, the others are RNA, and this is very specific just for humans. So is it related to some of the other viruses for ducks or squirrels? The thing is that this DNA overlap genes that will encode some protein syntheses, and this is for producing antigens. So you can have hepatitis B of surface, core, or type of an E-type and viral antigen. So just to understand surface and core and some E-type, this is something that has to do with when it appears after infection, what type of convalescent period you might have. Antibodies will appear at one time, but if it persists in chronic hepatitis, then does not produce antibodies. The only other thing important here is to remember that they can be persistent in chronic hepatitis, and they can give some markers in some way. In features, this appears in about over a month to about 6 months. One of the things is that hepatitis B here is after blood transfusion or contact with contaminated blood, and also with sexual contact. So the thing here for hepatitis B in your case is to, as a clinician, see of these possible ways of transmission. Understand that there are 3 phases as clinical picture. The pre-icteric, where before it gets yellow, is going to be weak, some nausea, vomiting. Probably might have, you can touch a little bigger the liver, and even sometimes the spleen, if that's been a little bit more chronic, and dark urine. Remember that you're going to have Coca-Cola type in this case. Pre-icteric is not the same as pre-hepatic. Icteric is when you already are yellow. Less than 30% will have it as about in 2 months. Clinical is getting worse, but typically the more jaundice you are, the more yellow you are, the better recovery you'll have. The convalescent is the more of this yellow you have an eventful, but mild jaundice, protracted course, typically will lead to a chronic hepatitis. So this is something to show about viral hepatitis B as incubation period and time, when it appears and what type of antigens you're going to have as surface or core or E, and then what type of antibodies you'll have. By years, you can have in some of them forever present those antibodies for hepatitis B. In the types of those antigens, are you going to have, and the time and markers are important to see that all of them are going to be present for about 4 months, perhaps, or for 12 weeks. So 30% will be affected. Elevated enzymes as AST and ALT are important to manage the chances of liver function or liver damage in this matter. So outcome are here, more a statistic than anything, but the important thing is that carcinoma is rare for this type of hepatitis. They might remain with some chronic hepatitis, but 25%. In chronic hepatitis, a mild presentation versus a severe presentation, where you can see here, read that inflammatory changes to the portal tract, and here, inflammation and fibrosis. So the thing is that here is closed, the portal, and here is just with some inflammatory changes. The other types of hepatitis is D, C, and E. The D is an RNA, has to do with B and A. Hepatitis B and D may be a co-infection, or even consider D a superinfection following hepatitis B. So only in superinfection, asymptomatic carriers will activate the disease. The other thing is that infection the hepatitis D, diagnosed demonstrating antibodies will be present. In type C, or the hepatitis C, encodes also a polypeptide and synthesis of protein. The important thing here is same thing, infected needles, so a little bit of blood transmission here. Sexual promiscuity is another situation, and anything that has to do with blood as contamination could be present. As a caregiver, you have to be careful of all these situations. Now, here, as hepatitis C carcinoma, it is a late complication of this cirrhosis. 25% will develop cirrhosis, 50% chronic hepatitis. So hepatitis C is not a good thing to have. In hepatitis E, as in A, is a fecal oral route. The thing is here is basically in by water-borne epidemics. So it has to be in areas where there's a rainy season. Africa, Asia, South America, up to Mexico will have it as a possibility, but it's not as current. Now, the only other thing is that hepatitis A and E will not cause chronic hepatitis or cirrhosis. So the thing that has to do with fecal oral route will not lead into chronic hepatitis or cirrhosis. The ones that are related with blood transmitted or blood-borne pathogen, it is going to be a problem there. Causes of cirrhosis. Why would you have this as chronic liver disease? So loss of normal liver structures present. Cirrhosis is the end stage of a liver disease. Typically it's irreversible and it's not curable, only if you get a liver transplant. And pathology, what you're going to have is a lot of fibrosis. Those liver cells, they're being replaced, replacing normal tissue. 65% of all cirrhosis is either by alcohol abuse or presence of hepatitis viral infection. And you already know that it'll be hepatitis B or C typically. Hepatitis and viruses B, C, D is the most common cause of viral hepatitis in USA. And some other frequent causes, you can read them here. Some will be hereditary, some autoimmune. I think this is a little bit more common. Others would be as drugs and biliary obstruction. So alcoholic liver disease means that the liver gets changed from alcohol. So there's necrosis of those liver cells. They are repaired by some fibrosis. They may regenerate. Portal cirrhosis, it means that the liver cells gets a necrosis, die. There's some ingrown fibrosis, but now the liver cells are not doing their job. And this takes years, 10, 20 years. Viral might take a faster course. But the thing is that once you have this, the portal cirrhosis is going to give all those changes that we already talked about, having a congestion for the spleen, ascites, having those varicose veins into the esophagus, and probably bleeding tendencies. Besides all those protein syntheses, the albumin that you require to close a wound, or to have something like the coagulation protein, the coagulation elements to stop a bleeding, they're not going to be there because the liver is not functioning. So it's important to see all those changes every time. So nodules or connective tissue and how you see it once this thing happens. So there's no normal tissue anymore. It's just an infiltration and changes of fibrosis. So portal hypertension complications, like I said, accumulation of fluid in the abdominal cavity. This is a peritoneal transudate. That's ascites. So portal hypertension and hypoproteinemia, low albumin, is going to happen. So remember the reasons for edema. Go back again and read that part and understand why you're going to have this. So the other thing that you're going to have with portal hypertension is a large big spleen, and you're going to have some anastomosis from the portal into the inferior vena cava. So hemorrhoids, you're going to have esophageal varices, and you're going to have what is called caput medusa, and you can see them in your abdominal wall. Typically, your face, some of the places. So what happens as the sinus goes is if you are not producing enough protein, albumin, you're going to have this term, hypoalbuminemia, which reduces that oncotic pressure of plasma, so fluid goes out from the intravascular space into the extracellular space. So because of that, increased transportation of fluid into abdomen. And what happens is then you start retaining water and sodium in kidneys because of a secondary hyperaldosteronism. So you can have these varices. In a little while we'll see some caput medusa, but this is fluid in the abdominal cavity. The spider, and this is the caput medusa here, as you saw in a little while, all these veins. This is called caput medusa. Large liver, or maybe small if it's very chronic now. Larger spleen. You're going to have this palmar erythema, purpura, because there's very easy bleeding tendencies because you're not producing coagulation factors. The spider nevi or the telangiectasia in the face is very typical also. Your parotid gland increases in size too. All your genitalia reduces in size. The thing with remembering that because there's a bypass to the liver, high ammonia is present, so hepatic encephalopathy is going to be happening. Changes of attitude, changes of personality, falling easy to sleep is going to be a tendency there. The hepatorenal syndrome is another situation where there's a lot of sodium retention besides the high ammonia, and there's a hyperperfusion of kidneys. So there's also another problem with kidney failure. So ALT, AST, like I said, those are transaminases, and this is directly related with liver cell injury. So anything that happens with liver cell injury, this is the way to detect it in lab in a biochemical study. And these are elevated. When liver function is lost, you're not producing albumin or the type of coagulation protein, so you're going to have low fibrinogen, and there's a bleeding tendency. And the other thing is that you're not being able to get rid of all those toxins. So ammonia, that's part of the catabolism or metabolism of proteins, are going to be high. When it's drug-induced, typically you can be considered this a predictable one as having necrosis and fatty change. Probably Tylenol, acetaminophen, is the one that is mostly related with this over-the-counter medication. So taking a lot of Tylenol is no good. The other has to do with chemotherapy specifically, and some specific viral medication or granulomas or for tumors are going to be giving that type of problems too. We already talked a little bit about Gilbert's disease. This is something that it runs in family. Typically, bilirubin is not as high as 3 milligrams. Males are more affected. There's no symptoms, so there's no treatment. And the most important thing, there's no complication of chronic liver disease. But I think if somebody has something like this, it has to be checked at least twice in life just to make sure that this is a correct diagnosis. And hemochromatosis is just a situation where you're accumulating a lot of iron in the liver, and this will lead into cirrhosis. This is probably a little bit more of a problem under certain circumstances, but nowadays, knowing that this is something that might happen, either you have a low iron diet or you have chances even to go on a weekly basis for phlebotomies, so to remove the accumulation of iron at one point. Wilson's disease and alpha-1 antitrypsin deficiency are two hereditary liver diseases. Wilson's is one that has to do with accumulation of copper, and this is something that's going to be in the liver, eye, and CNS. And what typically happens is that the liver cells are not excreting the copper and bile, and this is something that it's coming from one family to another in trait. It's something that can be known and stopped if there's no more pregnancies, but if it happens, it has to be sure that hoping that there's some specific type of medications as the penicillamine that binds copper and removes it. And some other agents, chelating agents, can bind to that metal and remove it. What you're going to see is in the eye some brown discoloration of the iris, and this is called the Kaiser-Fleischer ring. And the Kaiser-Fleischer ring is something that you can see. The bad thing about it is in brain, there's going to be some degeneration of some specific ganglia. And hemolysis might happen, also some acute episodes. In alpha-1 antitrypsin deficiency is one of the cirrhosis in children. It's the most common cause, very rare, but can happen. Immune disorders that happen with the liver as autoimmune, called primary biliary or primary sclerosing cholangitis. These two situations are sometimes might be fatal. They need sometimes a chance to have a liver transplant, but the thing is that it's autoimmune, occurs more in young women, and they're associated with other autoimmune diseases. What you can have is either some anti-nuclear antibodies or some anti-mitochondria type of antibodies. So the thing is with the primary biliary cirrhosis is a type 4 hypersensitivity or delayed sensitivity reaction as a created hypothesis. The thing is that these patients might have some antibodies to mitochondria. The sclerosing cholangitis is more in men, less than 40 years, but here is that is very close related with ulcerative colitis, much more than Crohn's disease. So ulcerative colitis can go also with what is called the primary sclerosing cholangitis. The primary biliary cirrhosis and sclerosing cholangitis, the first one has to do specific with the bile ducts, the primary biliary cirrhosis, and the primary sclerosing cholangitis has to do with the bile duct or hepatic duct going out to form the common bile duct. So most of these, like I said, have poor prognosis. They require some liver transplant. And the thing is that there's some constriction at those levels as for unknown causes. How does a liver get infected by bacteria? Typically through ascending biliary ducts. Could be blood-borne through a portal vein, or blood-borne through hepatic artery, or some direct inoculation with open wound or through wounds, or some extension from adjacent organs, like something that coming from the lungs and crossing for some reason through the diaphragm, or coming from the stomach, or from other of the organs close to the liver there. This is an abscess caused by this parasite, amoeba, the Entamoeba histolytica. This is the one that is going to cause this, and goes from the whatever you eat, it's contaminated, goes through the small intestine and jumps in through the blood and goes into the liver, and it's a perfect place for them. Doesn't seem to be much related with brain or muscle in other ways, because it has the same chance, but it stops there in the liver. Gallstones, as cholelithiasis or cholecystolithiasis, two different types of stones, one made out of cholesterol and the other that's called pigmentarious black or brown stones. They're from different sources. So anything that has to do some inflammation, or this can irritate the formation of stones, because eating a lot of, having high cholesterol level meals will deposit these salts there, and that could cause the situation that could irritate or cause some irritation, and that infection or some inflammatory reaction. Cancer of the gallbladder is not that common, but these stones can go out and get stuck in a way, and this will cause a post-hepatic jaundice because of the obstruction, or can either up here at the exit of the cystic duct, or can go all the way down before leaving into the ampulla of Bader. Some tumors, which are not that common as primary, they can be benign or malignant, and typically what you're going to have either as hemangiomas, they're most common. They're very small, no symptoms. The hepatocellular adenoma, very rare cancer, highly vascularized, and it happens to be present by bleed into the abdominal cavity. The hepatobiliary tumors, they can originate, or the source can be the same liver, bile duct, gallbladder, and very rare in Kupffer cells. The most important primary highly malignant liver tumor is a hepatocellular carcinoma. In children, it's called hepatoblastoma, which is rare. But the thing is that in presentation, some of the facts is that the AFP, the alpha fetoprotein, are going to be present in more than 50% of patients. So these cells, from a very specialized type of cell, become very unspecialized or very in a specific type of cells, and that's when they return to certain patterns of fetal, and that's when they start producing this type of marker in the serum. All of these patients will be having an early on stage of the disease, non-specific symptoms, loss of weight, fatigue, nausea, loss of appetite. So this can be anything. Could be tuberculosis, for what I care. Could be other type of tumor. Could be just a virus condition from other source. But typically, what you're going to have also is an enlarged liver, which is tender and painful. Eventually, portal hypertension will develop, having a large spleen, having those changes that you already heard. And once this happens, might have even an occlusion of that hepatic vein and venous congestion. Some other areas, as either cholangiocellular carcinoma or gallbladder carcinoma, the primary sclerosing cholangitis as a risk factor is for this type of cancer. Typically, all of them have a poor course in the disease, and typically they die, even though this one considers to have a better prognosis, as 35 live to 5 years, but 65 don't. Gallbladder carcinoma, like I said, it's not that common, but for some reason, hypotheses of harboring those stones have found to have some irritation, as chronic irritation there, and eventually the inner lining of the gallbladder changes and starts going into carcinoma. So the type of cancers are given here. Read the differences, know the location, as how they can look like, and the types of survival rate that they might have. As you can see, they're very poor. 20% to 5 years, 10% to 5 years, 5% to 5 years, and the best one is 35 to 5 years. But some specific changes that they might have, those are important things. All of them are going to give metastasis to regional lymph nodes, either lungs or abdominal area. More than that is the metastatic disease to liver, which is much more common than primary hepatic cancer. So if you're going to have hepatic cancer, most likely chances to have something that comes from lungs or breast or thyroid or any other source than or stomach than really having a primary. So GI, lungs, breast is going to be the most important primary tumors going into the liver as a metastatic condition. And this goes through portal vein or maybe arterial. Typically, you're going to see round nodules. The most common cause of this is what is called hepatomegaly, but hepatomegaly just means a large increase of liver. But when you talk about hepatomegaly and you don't have a cause, most likely you have to think about a metastatic condition. And this is only confirmed by liver biopsy. Liver transplantation is the only chance for an end-stage liver disease to keep alive. There's no dialysis, there's no way of doing nothing. Either you get worse and worse and worse, or you get a liver transplant. So anything that can cause liver damage like this is going to be included. Some metabolic disorders may be included here too. So there might be some antigenic differences between host and donor. So it's important for signs of rejection for this. And everything's going to be controlled, those immune response or reactions controlled by steroidal medication or some immunosuppressive drugs. Some of these host T cells will attack and ruin the function of that newly transplanted organ. So that's important to keep in mind. So this is what we'll cover with biliary and liver for this week. And any questions, please let me know. Have a good day.